Welcome to week 5 of the course. Congratulations on making it through some very tough material so far in the course. And today is also going to be another methodological lecture, and it's going to be some tough material, but I'm hoping to help guide you through it as best as possible. And of course, your assignment will be building off of this and be applying these lessons. So this week we're going to talk about operations research. So this lecture is on Introduction to Operations Research in Global Health. And we're going to talk about its application to global health, implementation science, and health systems improvement. So let's jump right in. So here's our agenda for the day. As an introductory lecture for operations research, I wanted to cover a background of what operations research is, kind of some of the history of operations research, when operations research is used, and steps in conducting operations research, some key definitions and types of operations research, and then show some examples of how operations research can be used in practice. So in previous years of this course, we only had the lecture from Dr. Joseph Heim, who's an expert in health systems engineering and operations research. This lecture is still available to you, and I highly suggest you watch this lecture as well. However, participants in previous iterations of the course had trouble understanding some of this material. So we decided to make this Introduction to OR lecture, and I'm using OR to represent operations research, to hopefully provide more of a background to this material. This lecture will be a start in your journey to becoming an operations research expert. And the second part of this lecture series will feature Dr. Sarah Gimbel, who will walk you through an applied operations research tool called the PMTCT Cascade Analysis Tool, so the Prevention of Mother-to-Child Transmission of HIV Cascade Analysis Tool, which helps use data to make decisions around systems improvement in the prevention of mother-to-child transmission of HIV. If you have time, after watching this lecture and Dr. Sarah Gimbel's lecture, I then suggest you watch the lecture by Dr. Joseph Heim last, which will extend your knowledge on this topic even further. However, this lecture is not strictly required for the course. So, if you remember back to the first Introduction to Implementation Science class led by Dr. Kenny Scher, he describes this figure showing the differences between operational, implementation, and health systems research. While language and terms always can be used differently by different people, in general, the term operations research focuses on local settings, often a clinic, a practice, or a small care delivery system that is interacting directly with consumers, which in our field tends to be patients, of course. This often includes working with healthcare providers and managers, as you see in this figure here, under the research users is healthcare providers for operational research. This could mean, for example, trying to improve flow in a clinic so that patient wait time is minimized, while consult time for patients is maximized. Often in operations research, we'll be focusing on identifying what we call optimization questions, or areas that we want to maximize in our system. With these optimization questions, we also have constraints, meaning other variables and factors that may need to be held constant, or have a certain ceiling that we can't exceed. In our example for optimizing wait and consult times at a clinic, we want to maximize consultation time and minimize patient wait time, right? Our constraints at our clinic might include a number of staff, number of hours of working time, the speed of different laboratory tests, speed of registration of patients, etc. So, as many things do, operations research is often called by multiple names by different groups. So it is often called management science, decision science, industrial and systems engineering. So management science in that it focuses on improving processes led by management within organizations. Decision science in that it focuses on using mathematical approaches to improve data-driven decision-making. And industrial and systems engineering, that it was born out of the optimization of assembly lines and other industrial and systems optimization questions. One definition that is used very often for operations research is a little bit more general, and it focuses on the use of advanced analytical techniques to conduct the analysis of systems Often we call them complex systems in that there's many interacting factors focused on improving decision-making, management, and ultimately outputs from the system. So the things that the system is producing. So that could be cars, if we're talking about a production system for cars. In our world, in healthcare, we're producing care and treatment for patients. So the modern field of operations research originated in the military arena during World War II, as it was a priority to improve the efficiency of the kind of military-industrial complex of many countries. So in World War II, there were over 1,000 men and women in Britain engaged in operational research. For example, they sought to use mathematical approaches to decrease the number of anti-aircraft artillery rounds needed to shoot an enemy aircraft down. So to give you an example of that, in the beginning of World War II at the Battle of Britain, they used 20,000 rounds, and in the end, they were only using 4,000 rounds. Another example in this initial use of operations research included the analysis of color of airplanes, which found that airplanes painted white were, on average, not spotted until they were 20% closer to their target than airplanes colored different colors. And so that led to Britain shifting so that all of its airplanes were painted white. So since World War II, operations research has spread much more widely across other fields. But it's still mostly applied to business and manufacturing to optimize the performance of supply chains and production lines. And it's really severely underutilized in the health field. Many people have advocated for it to be more widely applied, especially in global health and in healthcare in general. We know that healthcare costs have been increasing across many, if not all, countries, and healthcare is clearly subject to many constraints, such as lack of health workers. In the area that I work for mental health, many countries have less than 10 psychiatrists for the entire health system. So that's a constraint that we need to work within, and we need to figure out ways that we can maximize and optimize the performance of the mental health system, given we only have 10 psychiatrists, for example. There's also limited funding, a lack of medicines, and potentially inability to travel on roads during much of the year during rainy season. So with all of these challenges and constraints, many people have advocated for more operations research in global health. Recent analyses have suggested that operations research currently receives less than 3% of global health funding, with others suggesting that even that number is too high. So obviously, one of the reasons for us focusing on this in this course is to get more people familiar with the language of operations research, and hopefully it can be more widely used in the future to improve health systems. So after World War II, kind of moving forward into the modern day, Toyota Motors developed what they called the Toyota Production System, building on the success of operations research during this kind of World War II wartime. And they developed a number of concepts that together have been called, quote-unquote, lean thinking. The idea that the production system should provide the right parts in the right amount at the right time using minimum necessary resources. So at all areas of their car production systems, they have focused on eliminating what they call waste, using production systems level strategies. And the idea is that all waste decreases value to the customer. So if we're talking about different types of waste, the Toyota Production System, who kind of developed applied operations research and really rolled it out and revolutionized the car production and manufacturing process, they mention 7 major types of waste, which are listed here on the slide. So the first one is what they called correction or scrap, which is defective products, which is, of course, a major waste and decreases consumer confidence. In a health setting, this could be harmful tests or tests that need to work and don't, such as expired medication or a botched surgery or a lab reagent that doesn't work. This is obviously waste and could have severe negative health outcomes for our work in health. Overproduction which results in a loss of revenue. In a health setting, this could be wasted clinics or other health products that there's currently not demand for, that people are not seeking out. Waiting was the third type of waste. In the health system, the parts traveling through the production system are often patients, and wait time is a key performance factor, which leads to patient satisfaction and good health outcomes. Conveyance, which relates in the Toyota production system to the amount of space and time that parts need to travel, or humans need to travel. In a health setting, waste related to conveyance could be the need for patients to travel long distance in a clinic, or clinic workers that need to walk far away to get additional stock or medication. Another one is processing, which is basically wanting to represent and conduct the minimal amount of work needed for the outcome. So why would we want to do more work than is necessary to achieve a goal or achieve a good health outcome, or in the Toyota system, a good car? So we wouldn't want to do unnecessary tests that do not add value to health, or unnecessary work. Inventory, obviously wasted drugs, reagents, or staff time. And then motion, which is any unnecessary movements or actions in the production process. So as we're thinking about operations research moving forward the rest of this lecture, think often when you're trying to come up with what you might consider an operations research question that you would want to address in your setting. Think of what types of waste, what types of these 7 different types of waste exist in your setting, and how might we think about developing an optimization question and using operations research methods that we'll go through to eliminate this waste, or at least decrease the waste. In the lean thinking mindset, eliminating these different forms of waste add value to the product. In working in health, in our setting, the product is health of the population. So this is lean thinking in a nutshell. Here's just an example figure from the Toyota production system of the example of what they call just-in-time production, which was having the right products at the right time and the right amount. So we can imagine that a downstream demand, so on the right side, we have a demand for 100 units of something per day. That could be cars, or it could be, let's say, patients. So these 100 units can be produced in well, I guess we should probably use an example of maybe medication rather than patients, because we're not always in control of when patients need care. So you can imagine a downstream demand for 100 units of medication a day. These 100 units can be produced in a lot size of 1,000 once every 10 days, or it can be produced just in time in a lot size of 100 units each day. The lot size of 1,000 creates an average inventory of 500 across these 10 days here. Whereas the lot size of 100 units creates only an average inventory of 50. So you can see in the figure above, with the line going down from the top left of 1,000 units over the 10 days, yielding 500 piece average inventory in the middle here. And then you can compare that to the smaller lot size, where we get an average inventory of only 50 pieces. So the direct benefits in the Toyota production mindset of the smaller lot size are that the money invested in materials and inventory is dramatically decreased. The warehouse space needed to store the extra materials and parts is eliminated. The ability to respond to manufacturing processes are improved. So let's say there's a problem in manufacturing. If you created a lot size of 1,000, then you need to throw away maybe all 1,000 of those lab tests or medications, versus the smaller lot size, you can respond more rapidly to a manufacturing problem. And the level requirements place no excessive burden on employee or equipment. So we have less of a burden on the employees and equipment over the long term when they're producing a small amount each day rather than producing everything at day one. So one thing you can also think about as we're going through this lecture and this module is, how do we take these lessons from the Toyota production system, including just-in-time production, and build them into healthcare to maximize quality while decreasing what they consider waste, so the 7 different types of waste and potentially other types of waste, which will decrease costs and drive forward quality improvements and good health outcomes. So this is one key aim of operations research. So many people ask how operations research is different from monitoring and evaluation or quality improvement. So operations research is different from clinical or epidemiologic research in that it examines a system, in our case, a healthcare system, rather than focusing on an individual or group of individuals, as is in the case of clinical or epidemiological research, where patients are examined. That is, the performance of the system is our interest. So in a standard program logic model, as you see here, going from inputs, activities, outputs, outcomes to impact, often monitoring and evaluation focuses on tracking how well we're doing on inputs, activities, and outputs over time using monitoring. So we ensure our program is being implemented according to plan, and we troubleshoot any problems such as stockouts of medication or issues with human resources. And then the evaluation portion of M&E focuses on assessing the impact of our program on outcomes and impact in a population. Quality improvement, which you'll learn more about next week in Module 6, involves testing different change and improvement concepts in planning, doing, studying, and acting cycles to improve program, usually outputs, sometimes outcomes. But usually quality improvement doesn't evaluate population-level impact, as it's much harder to do in a short-term, small study. Often quality improvement studies aren't powered. They don't have enough people in it and enough statistical power to assess changes in impact. So they'll focus on outputs and sometimes outcomes, whereas monitoring and evaluation, often the goal is to show a change in population-level impact. So operations research is different in that it focuses on using mathematical approaches of optimization and simulation to answer questions of how best to organize the inputs, activities, and processes of our system. So here on the left side, you'll see the inputs and activities, and that these are focused on how. How is our system set up? How is it organized? And are mostly focused on resources. How are resources allocated? How are they set up? And what is the organization of our system or our program? So operations research focuses on using mathematical approaches to test and optimize how we can best use these inputs and activities and processes to maximize what we might get in the output, outcomes, and impact buckets. So in this way, it's more focused on the left side of this figure to develop mathematical models of our resources to maximize our results, whereas quality improvement is focused on a more applied approach to shift how we use our inputs and organize our processes in real life and in real time, and quickly examine the effects of these small changes on outputs. With operations research, as we'll see, we can conduct what-if analyses without actually having to implement the change in real life. This is not the same in quality improvement or monitoring and evaluation. I know this is confusing, so let's look at an example. So let's say we have a hypothetical problem. We have very long wait times at registration for primary care clinics. In a traditional monitoring and evaluation approach, we might implement a program shown to be successful at decreasing wait times and potentially adapt it a little bit to our setting or our context. We might develop an evaluation framework to either randomize some clinics to receive the intervention and not, or just implement the program across all clinics and conduct some sort of quasi-experimental design, as you talked about in impact evaluation, to examine the effect of this program. While the program's underway, we might monitor program activities, tracking the activities, inputs, and outputs, which feed into our understanding of our impact evaluation at the end of the project. We might conduct a survey pre- and post-program or use routine data to evaluate our program using something like time series analysis. If this implementation works in our clinic or district or province, we might develop some sort of cost model to understand how much it costs and then try to get it scaled up at the country level. That's kind of a traditional M&E approach. In a quality improvement approach, which you'll learn more about soon, we're more focused on an individual clinic level rather than seeking to implement a program on a district or province level. We would work with clinic staff to develop what they call a change concept or an idea of how we might be able to streamline our clinic activities to improve patient flow and decrease this long wait time, which is our main problem we're focusing on here. We would then potentially implement a change to test the idea of scheduling patients for one day, or for a few patients to see how this affects wait time in a small test at our clinic. This wouldn't have a formal impact evaluation, but instead would be focused on examining initial feasibility and initial effects of our program, our change concept on wait time. If this small QI test, quality improvement test, were successful, we might consider scaling it up and testing it in a larger program, which then might necessitate more of an M&E approach, which we just described. Operations research is a bit different. It focuses on addressing operational issues and systems organization of resources, processes, and inputs. This may sound a little bit obvious, but it can get tricky, and the distinction sometimes is not completely clear. Many people often put forward more monitoring and evaluation questions when beginning to think about operations research, but fail to think about how you carry out your programs from an operational perspective. In the above example, an operations research approach might be to develop a simulation model, which would be a mathematical representation of patient arrivals to your clinic and patients exiting registration, given the real-world data from your clinic and the constraints, like the clinic's open at 7 a.m., and it closes at 3. We might have 2 doctors. Some days we have 1 doctor. We might have other constraints, like the amount of time it takes for a patient to get seen. You would then seek to validate this model to ensure that it accurately describes the real-world phenomenon of waiting time at your clinics. You could then conduct what-if analyses by, let's say, shifting to clinic appointment schedules or shifting human resources around the clinics. However, this would not involve actually carrying out the tests and actually doing this in the real world, as in the QI model or the M&E model, because your simulation model stands in for your real-world clinic. So many people tend to apply either the QI or the M&E approach when they begin to think about operations research. For example, they might ask a question about what is the effect of clinic-based versus community-based models of chronic disease management. So is it better to have it based in a clinic or led by a community health worker? That question is different from asking an operations research optimization question like, what is the optimal frequency of patient clinic visits and community health worker home visits in a chronic disease management program? The latter question gets at how the program is operationalized. For example, how staff resources are allocated, how frequently services are offered. To think from an operational perspective, you must think about the nuts and bolts issues of how a program is delivered. How should appointments and queuing for services be handled? What are hours of operation and frequency of visits? Do we organize one-on-one education or group education sessions? How do we manage supplies? All of these are operational issues where operations research methods can help us understand the best choices and the effect of these different ways of organizing services. That first question of what's the effect of clinic versus community-based models, that's more of a large-scale M&E question that you'd want to do a large study with multiple clinics and test impact, versus the other ones are more just how it should be organized to maximize program effectiveness. Another key element to keep in mind is that performance measures of interest in operations research need to be closely tied to these operational concerns. Throughput measures, or measures of the number of items or patients moving through a system, that could be number of clients reached, could be cost per service or unit, and waiting time, for example, are typical measures in operations research. Performance measures can also address health outcomes, like number of diabetic patients achieving stable blood glucose control. If you do this, it's generally best to select proximal health indicators rather than distal measures of morbidity and mortality. It's better to choose indicators that are directly impacted by the system, let's say at the clinic level, rather than doing overall mortality, which might be more affected by factors outside of the clinic. Keep this logic framework in mind, in that we're focusing on the how here on the left side and the resources in operational research. We're focused on how should inputs and processes and activities be organized to optimally achieve program outputs, outcomes, and impact. So there are a number of analytical tools for operations research, some of which are qualitative, thus more contextual, and less amenable to being captured in numbers. And there are those that are quantitative in nature in the bottom right on this figure, and the qualitative ones here are in the top left. Often those that are qualitative are more focused on groups in participatory sessions to improve operations and management, whereas those on the bottom right are often more used by individual analysts who then report findings of this analysis to groups in presentations and meetings. For example, behavioral simulation and scenario analyses involve a group of stakeholders, say clinic employees, acting out a system change or a problem situation to gain insights, which could then inform future simulation, modeling, or quality improvement. This is a sort of simulation, which here is listed as discrete event and agent simulation. So that's a simulation model. But it's not mathematical. It's that you're simulating the system in the scenario with people rather than in a mathematical format. As an example here, there's system mapping. So system mapping can help understand the complex interrelationships amongst a given system and identify areas of improvement and areas where there might be bottlenecks. Oftentimes, individual workers do not have a full picture of the system because they might be working, let's say, as a CD4 nurse here in the top right of this figure, but they don't work at reception. So they don't know all the factors that happen at reception. That might be delaying people's ability to come see the CD4 nurse. As an example here, this figure is the flow of people through the prevention of mother-to-child transmission for HIV in Mozambique. It's a very complicated graph and system, which necessitates systems analysis and operations research. So we will focus most of the rest of this lecture on the quantitative approaches. So this is an example of a qualitative approach in that this system map couldn't easily be captured in a number from 1 to 10 or something like that. But it still is very helpful to feed into the development of simulation models or optimization models, which could be used to then improve the functioning of the system. So we're going to focus most of the rest of this lecture on the quantitative approaches of simulation modeling and optimization. But just keep in mind that all these definitions are fluid, and there are other approaches that are both qualitative, that might meld optimization and some types of simulation. And there's methods that use more traditional statistical analysis, such as we find in biostatistics, and we talked about more in the impact evaluation. So keep in mind that this is all fluid and a developing field, especially in the global context. So there are two main types of quantitative operations research that we'll focus on for the purpose of this course, which I mentioned a little bit previously. These include simulation modeling, often called discrete event simulation or agent-based modeling. And those are contrasted with optimization approaches, which is often called linear programming. First, let's talk about simulation modeling. This approach focuses on building a simulated model of your inputs, processes, outputs, and sometimes impacts, and the complicated interaction of all these elements in your system. This approach results in descriptive findings, rather than one best or optimized singular solution. This is important, so focus on that, and it's underlined in red here, so it should be clear that this is one of the key things to remember. As we discussed above in the operations research example for wait time, a simulation model can also allow testing multiple what-if scenarios to examine the impact of changing your system's organization, so the organization of your inputs, resources, and processes, to then guide future testing or implementation of that. There are some key questions for simulation models when you're thinking about implementing one. You want to ask, what is moving through the system? Is it a part? Is it a medication? Is it a person? What activities happen to the things moving through? Are people assembling a vehicle? Are people testing the quality of a drug? Are people providing care and providing surgery to patients with knee issues, let's say? What resources are used to accomplish those activities? What are the response variables to measure system performance? What is the purpose of the system? Is it to produce high-quality cars? In the medication example, is it to produce high-quality medication that's of a good potency? And in the knee surgery example, it's to decrease disability associated with knee injury and potentially not have side effects from a surgery. And then the last one is, what are the relationships between the actors, the activities, the resources, and the response variable? Do they all work together? Are they working separately? If one fails, does it have an unpredictable relationship to another? And we'll go over some examples that will hopefully clarify that. As you can see in this figure, I wanted to put this up here just to give you an idea of how complex this can get in the real world. So simulation models can get very complicated very quickly. In fact, both simulation and optimization problems in operations research can become very complex and require high aptitude with applied mathematics and high levels of computing power and specialized software. But they don't necessarily have to be complicated if you make a number of simplifying assumptions, or are interested in studying one small part of a larger system. Let me just say that again. It's okay to make assumptions when you're making these models. We always make assumptions as we can't model every potential interacting piece of the real world. So we always are making assumptions, and all models make assumptions. So on this slide, you'll see an example of a simulation model of patient flows in the emergency department of a health clinic in Canada. You see patients on the left side here. I know it's kind of small, but this left box here that I'm circling is patients waiting for emergency medical services. So these patients are waiting for like an ambulance, let's say. You see these patients then go to the waiting rooms and might wait for services in the emergency room. And there are also patients who are referred, who don't come through emergency medical services. Patients who are on waiting lists, people who got referred from their general practitioner and then are coming to the ER, let's say. So you can see then all of what we call the complex interrelationships among variables, such as availability of doctors in the ER, the availability of lab services, the availability of consultants, nurses, that the beds are available and operational, that people are waiting for a certain amount of time, which affects demand and affects people who might leave without being seen because they're waiting so long. You can see all of these factors are then included in this model and will create a simulation of what the system is like to try to treat people in emergency rooms in Canada. So if you developed this model and you could show that it faithfully could really represent the behavior of the system as a whole in Canada or in one clinic for emergency room visits, you could then modify some of these inputs to see which might give you the best, quote-unquote, bang for your buck, as we call what-if analysis, to improve the functioning of the system. So perhaps your what-if analysis could be hiring more consultants. So over here, there's an assumption of consultants available. So maybe we could hire more consultants. Or ward beds are available, which is here. Or emergency room beds available. Or doctors are available. So we could change all of these a little bit. We could say, let's say, what if there's more emergency room doctors available? How would that affect the performance of the system? What if there's more lab services available? More consultants available? Which one of those would give us the best improvement in our system? And then we could consider actually implementing that in the real world and testing it through either a quality improvement approach on a small scale or a monitoring and evaluation approach with more of a large structured program. So the other main type of quantitative operations research is optimization. Whereas simulation is mostly descriptive and focused on these what-if analyses, optimization focuses on developing a system of mathematical equations that focus on maximizing or minimizing some performance outcome that is a function of, that is related to, or what we call in mathematical terms a function, of decision variables, as well as some constraints. So this results in the mathematical approach to identify the singular best solution given these variables and some constraints. So here, this is another important thing to know. So the difference between simulation and optimization is that optimization is focused on identifying a singular best solution given a complex series of mathematical equations and variables and factors that are interrelating and constraints. Whereas simulation modeling is focused more on describing the world, creating a representation and a simulation of the real world, and then using that to describe it and potentially test some alternative implementation strategies. So some key questions if you're thinking about doing an optimization approach are, what is your singular goal or outcome to maximize or minimize? Here on the right side, you can see an example of a surface that might have been generated from a mathematical equation. And then at the top, you have this arrow and this maximum point of the surface. So let's say we're trying to maximize patient consult time. This could be the point in the equation that, given all the factors, maximizes patient consult time. What are your inputs, process, and decision variables? So what are the factors that are relating to, let's say, patient consult time? And what are your constraints, which could be anything, but in this example, it obviously would be related to clinic hours and number of doctors to see patients, etc. So oftentimes, optimization approaches are used extensively for scheduling of complex systems. So they're used extensively by airlines, by sports teams to schedule an optimal different competitive factors for sports teams, but also for airlines to schedule flights that make the most sense to maximize profit by the airline. And then also for supply chain, for large companies like that are delivering products to people's houses, how to maximize the transportation of those different things. So that's an example of areas and sectors that most often use optimization. But we should consider how we can use this in global health. So here is an example figure of the steps to conducting a simulation model. There are some key steps to consider before you develop the model, and when you're developing the model, and then post-model. So first, at the top here, you might want to form a steering committee of experts who will help inform how you're going to develop the model. How can you develop a model that faithfully represents the system that you're interested in? You also will need to identify the system processes and performance measure of interest. And then you might want to collect data to inform the development of your model. So this example here, the data was the purpose of this model was to do a time study to look at waiting time and consult time at a clinic. So they collected data around true wait and consult times in a number of clinics to then inform how they could develop this simulation model. You might then create a conceptual model of, let's say, the flow maps and how patients flow through the system, as well as developing assumptions and constraints. So here in this next slide is an example of, in this study, how they developed flow maps to initially conceptualize the process of what happens when a patient arrives up to when a patient is discharged at primary healthcare clinics in Mozambique. So this is an example of a rural health center. The patient arrives. Is it a pediatric patient? Do they need immunization? If they're not a pediatric patient, the nurse treats the patient. Do they need lab or pharmacy? And then they go through these different things. So that's an example of what you might do at the beginning of model development. Here's another example of more of a causal model of patient satisfaction, which can serve as an initial concept to create a simulation model. So you might want to know all the variables and the factors that influence on patient satisfaction if you're going to create a simulation model. And how are they related to each other? So you can see in this model that there are a number of pluses and negatives showing the estimated and hypothesized associations. Some even have references, so they're taken from previous studies that might have assessed the relationship between these different factors. So for example, in this figure, overall population is positively associated with the quantity of patients here, as you would expect. As the population goes up, the number of patients you're going to see is going to go up. the cost of services is negatively associated with patient satisfaction. So as costs go up, patient satisfaction goes down, as you might expect. So this here is the cost of services, and here's the negative association with level of patient satisfaction. So you would use this then to understand the different complex relationships between all the variables that you might want to include in your simulation model. Because what we need to do is we need to specify these variables, specify how they relate to each other, and then we can see whether our simulation model truly reflects reality, and then we could test some of those what-if scenarios to guide further system improvements. In the study I was talking about previously for the time study in Mozambique and to create a simulation model of wait and consult time, we also need to create a detailed list of patient assumptions, facility assumptions, and worker assumptions as we try to build this simulation model for wait time and flow of patients through clinics in primary healthcare centers in Mozambique, for example. So you can see the level of detail here. For example, we have said that patients begin arriving at 7:30 a.m. in our simulation model. This is based on data we collected in Mozambique that patients do often begin arriving at 7:30 a.m. On average, 70% of the patients in our model are adults, 30% are children, pediatric. 60% of the adults require only pharmacy services, 10% require only lab services, and 30% might require both. So you can see the level of detail that we need to specify in the simulation model to approach something that actually reflects reality rather than just making up a simulation of something that doesn't represent anything, right? So we said that the hour of operation of the health facility are between 8 a.m. and 2 p.m. So you can see in this model that patients begin arriving at 7:30 a.m., but the clinic doesn't open till 8 a.m. So the wait time actually will be often highest right when the clinic opens, which is actually our experience in Mozambique, and is one of the challenges. And you can see the simplifying assumptions that each healthcare worker provides services continuously during hours of clinic operations. It would be much more complicated to include lunch breaks, bathroom breaks, etc. for all the clinics in the model. So we make the simplifying assumption that they're providing services continuously. So you can see here are patient assumptions, facility assumptions, and worker assumptions. So we're always making simplifying assumptions around our model because we can't include every factor. We just want to include the factors that are most important to create a simulation model that faithfully can represent the thing of interest that we're interested in studying, which here is wait and consult time. So unfortunately, in the example that we were showing, we had trouble validating the waiting time model in that it did not appear to represent the initial survey data and then real-world functioning of the clinic. So when we ran the model under different circumstances, it didn't behave well. It didn't make sense. And so the suggestions going forward were to improve on the data that we inputted and potentially change around these assumptions. Because the initial data that we collected was just focused on mean wait times, but we need to figure out the true distribution of wait times and use them to then feed back into the model. So you can see on the pre-model, the last one is validate the time study data. Okay, so we did that. So then you construct the computer simulation model, and then you verify and validate the simulation results. So in Mozambique, we got to this point, and then actually we couldn't validate it. Their model didn't make sense. So it didn't make sense to go to the next step, which is to design and perform the what-if scenarios. What's the point of saying, okay, well, what if we switch to appointments? Or what if clinics opened a little bit earlier or stayed open a little bit later? How would that help the situation? It doesn't make sense to do that if the model doesn't even really reflect reality. That would just kind of be a waste of time. But if the model was validated in our setting, we could have done some of those what-if scenarios and experiments and analyzed those data. And then you can use those data to then inform implementing a new policy or testing let's say the what-if data said, okay, if clinics were to open 30 minutes earlier at 7:30, that might solve your problem. So then you could do a small test of looking at what happens if you open the clinic a little earlier. Alternatively, you could use the output data from this tool, from the simulation model, to design a tool for wider use. Let's say an Excel-based tool that has the model parameters built into it, but the people only need to know how to enter things into Excel to look at the impact of changing some of the parameters in their facility. And then obviously you might want to document and share your results, and then build your model findings into continuous improvement or implementation of quality improvement and more programs that you might evaluate using a monitoring and evaluation framework. So the field of this complex simulation modeling is relatively new when applied to healthcare, but it already has some guidelines on what might differentiate the simulations modeling from the more traditional optimization models, focusing on finding the one best solution, which we'll talk about next. So you can see on the right side there's this thing called the Simulate Checklist, which kind of asks some questions about what are you trying to do, and does your problem require these different things? And if so, then it makes sense to consider a simulations model rather than optimization model. So I'll just go through a few of these, and you can read through the rest if you want in more detail. But for example, the system, are you modeling multiple events, relationships, and stakeholders representing healthcare delivery processes? Are you including nonlinear and spatial relationships among stakeholders? And do their behaviors make the system difficult to anticipate? So you need to create a simulation model when you can't just write down a mathematical equation to solve your answer. You have many different doctors who are interacting with many different patients in different ways. Some patients are getting this treatment, some patients are getting this treatment. And because of those complex interactions between those things, potentially also contextual things outside of the clinic, as we saw in the Canada emergency room simulation, there are so many variables and so many complex interactions that we couldn't really just write one singular math equation to solve that. So in that sense, there's many interactions that are nonlinear, and they influence behaviors that they make the system difficult to anticipate. Are you doing analyses on different levels from strategic or operational perspectives? So you might want to create simulation models for multiple levels of the system. And then, there's a few other ones here. Are you doing feedback loops so that future interactions, that current interactions change future interactions, which then might also feed back into the system in complex ways? Are you doing time-dependent relationships? And are there unintended and intended consequences you want to be able to examine? This gets a little complex. If this is a little bit confusing, just come back to the general idea that the simulation model focuses on describing and then potentially doing what-if analyses, whereas the optimization model focuses on identifying the one best solution and maximizing or minimizing something. So again, we can look back at this emergency room model from Canada. So just to contextualize this a little bit, over the past decade, Calgary's population in Canada grew without increase in the health system capacity. So there was an increased demand for space in the emergency room wards, which caused further backup in the emergency room, further increasing the length of stay, the average length of stay in the ER, which further increased this problem. So they wanted to create this model to try to figure out, okay, what can we do about this? And we already described the model a little bit. But they wanted to answer specific questions. They wanted to know, what effect does a shortage of family physicians, the potential ER docs, what effect does a shortage of that have, and what effect does a shortage of consultants have on the overall performance of this ER treatment system? And then what effect do policies on a higher level have around people going to the ER, the number of patients admitting to the ER, and then flow of the patients being admitted to different ER wards? It's just to give you an idea of an example of a real model that people were actually presenting at the 25th International Conference of the Systems Dynamics Society, 2007. So I want to here just show you this quick video from YouTube, which just gives you an idea about what this kind of looks like. So here is another emergency department simulation that someone ran, and it's very complex. It has this fancy, visualization here. But you can see the patients coming into the waiting room and waiting there, the simulated patients, not the real patients. Then some of them being seen in the emergency room, 1, some people going to emergency room 2, some people going to triage, that there's a certain number of doctors and nurses and PAs that are then available to treat patients, and at certain points right now there's no PAs, so it'd be difficult for people to be seen. Some people need to go to the X-ray. So just to give you an idea that this is kind of what it looks like, in that we're simulating the functioning of an ER system, and that simulated patients are actually kind of going through the system and being seen at different things, at different areas, and then there's a certain number of doctors and other things that are all interacting. And then at the bottom, they had some bars that were going up and down, tracking some outcomes that they might be interested in. Just to give you kind of an idea and a feel of what a simulation model might look like. All right, now let's turn to optimization. We've talked about it so much. I know you're just so excited to turn to this and to leave simulation behind. Let's talk about some steps that you might do to conduct optimization. Now remember, I know I might sound like a broken record, and I apologize for that. But remember that in optimization, we're trying to maximize or minimize some outcome of interest. And this approach results in the one best optimal solution. We're not testing what-if scenarios, but we're developing a model that tries to faithfully represent our system, factors that influence on our system, and constraints, and then just solving these mathematical equations and getting an outcome. I know many of you have done algebra or higher algebra or calculus, where you might have a system of equations, system of linear equations, which you then solve for the unknown variables. That's the same idea here, and we'll go through a few relatively simple examples to give you a feel of this as well. So when you're thinking about doing optimization, first, you need to define your outcome, the thing you're interested in optimizing, in quantitative, in numbers. It can't be qualitative. It can't just be, it couldn't be one of those flow maps. It wouldn't be clear how to put that into mathematical equation terms, right? So you need to figure out what it is that you want to maximize. You could also minimize it. So you could talk about maximizing the number of patients seen in a week, or you could talk about minimizing the number of lab tests needed to optimally treat patients, let's say. Depends on what you want to accomplish. So second, you need to define your decision variables, or key factors and variables that are impacting on your outcome. For example, what is it that affects the waiting time at a clinic? So we've used this example many times. So the number of doctors might impact on this. The number of patients obviously impacts on this. The number of beds available. So it could be similar type of factors that influence on your outcome as in the simulation model, but usually isn't as complex as we saw in that ER visit, but it could be, because you could put that into a system of equations and just get one solution. In that situation, what they're really interested in were testing different potential what-if analyses of number of ER doctors and other things, rather than trying to optimize something given what they have, the resources that they have. You then need to define your constraints. So these things that you cannot exceed or you cannot go below. So you might need to have, let's say, one doctor, one nurse, and one PA, because that's what the Ministry of Health says is a minimum for your clinic, for example. So then you'll solve these equations to get this one best optimal solution. So I know this figure is a little bit much, but I'll walk through it a little bit slowly. It's just an example, a kind of simplified example of optimization. So here is this simplified example. It's simplified for the purpose of this class. Often these questions are incredibly complex and can't be solved by hand and can't even be put in a 2D space, as we saw previously with that 3D kind of surface, right? But we simplified this just so you can kind of get a feel for what it's like. So for this hypothetical question, let's imagine we have some type of gasoline that we're producing from oil. We want to maximize our profit. I know this isn't health related, but a lot of these methods come from business, and this could be a health-related one too. Which actually, our next example will be health-related. So we want to maximize our profit from this oil. We make $8 for each gallon of premium gas that we produce, and we make $2 for each gallon of regular that we produce. So these are an example of our kind of decision variables. We're making premium and regular gas, or we can make premium and regular gas. We want to maximize profit, so we defined our outcome. And then premium, we get more money for than regular. Those are kind of the factors influencing on our decision making, right? Our decision variables. So we did step one, was to define what we want to optimize, and we defined our decision variables. Next, we need to add in constraints, which are listed below the graph here. So we need to create more regular gas than premium. That could be set by our bosses, or it could be set by the market or something, right? We can't create more premium than regular. So that's just a constraint. Because, if you knew nothing and I told you make $8 for a premium gallon of gas and $2 for a regular gallon of gas, you just produce all premium, because why would you take the $2 when you could take the $8, right? We also need to create more than 5% premium. And we need to create more than 5% regular. I'll draw the percents on there. So those are our constraints. More regular than premium. Premium we have to produce more than 5% premium, and we have to produce more than 5% regular. So the first one we can call the lost waste constraint, which we can put on the graph, the percentage constraint, and the cost constraint all on the graph. We have to produce more premium than regular. So that's here on the graph. We have to produce more than 5% premium. That's on the graph. We have to produce more than 5% regular on the graph here. So with all of these different constraints put on this graph, these different lines that are constraining our choice, because otherwise we might say, okay, we want to produce all premium, or we want to produce all regular. Well, that stands outside of our areas if you combine all of our constraints. So the area that we can consider then is this shaded textured box within all of our constraints. So we could choose any value in here that would satisfy these constraints. So we could choose about, 10% premium and 20% regular. Let's say right here, I'll just put this point here. So that lies within our all of our constraints. But it probably, given where it is in this figure, it probably doesn't maximize our profit. We want to maximize our profit. We don't want to just choose randomly, right? So if we solve this system of equations, we get that this x here is the optimal solution, the one best solution to maximize our profit. So that is with premium making about 12.5%. I'm going to draw the percents on here again. And making 43.75% regular. This maximizes our profit. So you can see how this is different from the simulation modeling, in which we're trying to create a descriptive representation of our system to test kind of what-if scenarios. Here we're trying to get the one best solution for how to maximize gain or maximize the system performance given a set of constraints. Let's look at another example, one that's more health-related. So here is one other example of optimization in the healthcare context. Let's say that our clinic has two services it can provide to patients to solve a clinical problem, okay? One is a complete blood count, which here is, in this figure, CBC, complete blood count. And you can see here, CBC. And one is a genomic-based test. So there's genomic test, GNO, which is here. You can see that there's a certain amount of profit per unit for CBC and GNO. So each time we do a CBC, we get $40. Each time we do a genomic-based test, we get $50. So again, if you had no constraints, you might just do all genomic tests because you're getting more money, right? And let's say, again, we want to maximize profit for this example. I know normally in healthcare, we're not about maximizing profit. We're about maximizing population health, but just use this as an example. And often for-profit companies will want to maximize profit. So this is how they'll use these methods. So, like I said, if you didn't have any constraints, you just produce all genomic tests, right? But we do have constraints of our resources, and each test requires a different amount of resources. So the genomic test requires 2 units of healthcare worker time per test. You can see here in the figure. And the genomic test requires 3 units of materials, or here it's called a kit, right, per test. 3 kits per test. Whereas the complete blood count test requires only 1 unit of healthcare worker time, and however, 4 units of the materials or the kits per test. So these resource variables and how much each test requires, along with the cost and the fact that we are doing complete blood counts and genomic tests, those are our decision variables. So we also have a limited availability of materials, which are constraints. So the above numbers of resources, CBC, that we're doing CBCs, and GNOs, the profit per unit, all of that are decision variables. But we also have limited availability of materials. So you can see we only have 40 units of healthcare worker time and 120 units of the kits for the materials. So those are our constraints. Again, this is just an example. We could change the outcome to not to be profit, to be number of patients seen in a day, or number of patients with blood pressure below a certain threshold, or any quantitative element we might want to maximize or minimize. Remember that. So the purpose of this is we want to determine the best mix of how many CBCs we're going to do and GNOs given our limited materials and our limited healthcare worker time, right? So again, we can put this into equation form. So you can see that here. That line was not that straight. That was a little straighter. So you can see that here. So we want to maximize profit, which we call Z in this example. So our profit equals $40 for each complete blood count and $50 for each GNO. So you can see 40 times X1, which is CBC, and 50 times X2, which is the genomic test. So we want to find the optimal distribution of X1 and X2. However, these are subject to constraints. So our first constraint is that X1 plus 2X2 has to be less than 40. Where do you think that equation comes from? How do we get this constraint to put in here? So this constraint comes directly from here in the table, that it costs 1 healthcare worker unit time and 2 1 healthcare worker time for each complete blood count and 2 for each genomic test. Okay, so here there's 1 here. You could write it in. X1 and 2X2. And those have to be less than or equal to 40 because we only have 40 healthcare worker time units available, right? So then the second one, it's subject to this other constraint, which is about materials. So 4X1, 3X2 have to be less than or equal to 120 because we only have 120 units of materials, and it costs 4 for each CBC and 3 for each genomic test. And then last, we can't produce negative services. So we can't do negative complete blood counts. So we just say, for the purposes of this model, that X1 and X2 have to be greater than or equal to 0. Because it's just a mathematical model. It doesn't know that it can't do negatives. And so it could do something funky if we didn't say that. So we put that in there too. So what we do then is we solve this system of equations. And you can see on the left the graphical version of kind of this simple question, right? So we have the 4x1, 3x2 line, and then we have the x1 plus 2x2 is less than 40 line. And the area that they intersect actually happens, similar to the other one, to be the optimal solution. So you can see here, we could do it graphically, but we can also solve it, and we get the value of 24 x1 and 8 x2. So that's 24 complete blood counts and 8 of the genomic tests. And these together yield a profit of $1,360, and that's our maximum profit. So you can see here that, again, this is a very simplified example, but you could make it more complicated, but some questions you can gain important knowledge about health systems functioning and how to best allocate your resources, the how side of the inputs and processes of that initial logic model, using some relatively simple mathematical solutions. All right, so that was some intense material, and thanks for sticking through it. And let's just go through a quick summary. So, operations research is focused on applying advanced analytical techniques for systems analysis with the goal of improving the functioning of the system. It focuses on eliminating waste. You could consider the 7 wastes of the Toyota production system that we talked about at the beginning. But it's focused on lean thinking to simultaneously decrease costs of the system and increase value of products and the whole system. For us, again, that might be decreasing costs of the healthcare delivery system and increasing population health or increasing patient satisfaction, let's say. Operations research is different from monitoring and evaluation as well as quality improvement in that it focuses on the how questions around systems inputs and processes rather than on systems outputs, outcomes, or impact. As we talked about, monitoring and evaluation really focuses on impact, often at the community level. Quality improvement, you enact small changes to look at differences that might originate at your outputs and outcomes level. Oftentimes, operations research involves simulating something that is focused on the how question, but doesn't really involve implementing something that would then change outputs, outcomes, and impact in the real world. So just keep that in mind. Again, we talked about 2 main quantitative methods used in operations research. These include simulation modeling and optimization. Simulation modeling creates a complex representation of the system to describe its behavior, often it's such a complex system that you can't just solve it through a system of linear equations. And then you might want to test what-if analyses to look at what might happen to the system if we actually implement some hypothetical situation. Optimization modeling, however, focuses on actually solving these systems of equations to maximize or minimize a target outcome, subject to these decision variables and constraints, and results in your one best answer. Thanks for spending time to watch this lecture. If you found this material interesting and engaging, I really suggest that you watch Dr. Joseph Heim's longer lecture as he goes into even more detail into these analyses and questions. However, there might be a little bit of repeat, but he does talk about different things, and it talks about it in a different way. The next step of required presentations is to watch Dr. Sarah Gimbel's presentation of the PMTCT Cascade Analysis tool. You can see that this tool and approach is not directly a simulation model or an optimization model. But this is something that is simple enough to understand and you can all experience and actually interact with the Excel tool and see how this sort of what we call decision support tool, a tool that is based on mathematical concepts but helps support better decision making when you're talking about systems improvement, and how it can help support making management decisions as well as targeting monitoring and evaluation, programs, or quality improvement. It's also kind of a simplified what-if tool, showing the number of people who would be additionally served by this prevention and mother-to-child transmission of HIV cascade if we eliminated specific losses to the system. And you can go in and you can change the numbers and say, okay, what if we increased the number of women coming in for first antenatal care visits from 1,000 to 1,100? What would that do to our system? And then where would we want to focus our efforts? So you can also see it as a sort of simplified what-if analysis. So hopefully you enjoyed the lecture and look forward to interacting with you in the discussion forums and reading your assignments. Thanks.